Good morning, everyone. Um, Welcome to We're All Patients podcast. My guest today is someone who's not just rethinking rural behavioral health, she's actively reshaping it. Dr. Sarah Scruggs is a clinical faculty member in the Department of Psychiatry at the University of Illinois College of Medicine in Rockford. She brings a rare blend of expertise with 17 years in biomedical research, 8 years as a social entrepreneur and CEO in community behavioral health, and a proven track record of building sustainable, data driven models of care. In 2017, she founded the Aruka Institute of Healing, launched a mobile, patient centered approach to care that empowers anyone, anywhere, anytime access to behavioral health services, especially in rural and underserved areas. By 2019, she had created a rural behavioral health consortium that brought together hospitals, schools, churches, law enforcement, and social services across thousands of square miles, all working in collaboration for stronger outcomes. What I find especially powerful in Sarah's personal connection to this work is that she grew up in a rural community, and her commitment to solving long-standing disparities in access and outcomes is grounded in both experience and vision. Sarah, welcome to the show. I've been really looking forward to this conversation.
Thanks, Sam. It's wonderful to be here. Wonderful to see you again.
So let's jump into it. You built a high access, data driven model of behavioral health, it's a tongue twister for some reason,
It's
for,
a lot of
for,
words.
for, for rural America. So you built this high access, data driven model. How did you go from being a scientist? Well, I guess tell people about your background. Like, it's fascinating to me.
Sure. So I am a scientist, trained in physiology and biophysics from University of Illinois, Chicago. I love science. I love the art of discovery. I think like a scientist. I have a very data-driven outlook on life and the work that I do. I was very happy in academia, as you read, which it's funny when, you're reading my bio, I'm like, oh yeah, we did that. It's humbling sometimes to think about all that we've done and where we've come from. But that's where I started. That was my research was my first love. And I worked on cardiovascular science actually, and we were looking at some biomarkers and things in heart failure and trying to understand how to reverse remodel the heart back to health. So I worked in Chicago and then I did my postdoc at UCLA and started my first faculty position there. Was very content in science. And I around my kids, I had my kids out there, my husband, my children and I were there. And my youngest daughter was 1, my oldest daughter was 3. And I remember getting a phone call from a family member talking about another family member that was really struggling with some behavioral health issues in Illinois. And at that time, they needed my help. And at that time, I was able to, what I thought was a transient move, move back to rural Illinois with my family, continue working in my position in LA, and attend to the needs of my family member. Upon doing so, I came back and just sort of started to observe what was happening in the community. I started walking through this family member's journey, their behavioral health journey with them. I encountered every barrier really on a daily basis that they were encountering. I felt every despair and every lost battle in doing that. I realized this was not unique to my family member who had privilege, had wealth. This was very much a systemic issue in that entire community. I was driving that family member 2 hours at least once a week to get proper treatment again, and this family member had commercial insurance, his family member had means. So very, very long story short, essentially that ignited a fire inside of me. And I said, we need to do something. This is where I grew up. This is where I live. There's thousands of people suffering here, and the stigma is particularly strong. So it really was keeping people at bay. People weren't able to get the help that they needed. They weren't able to reach out. And then they had enormous barriers to accessing care. So it's passion that ignited that switch. I would say if I launched that behavioral health center a couple years later. I planned with local people in the community that were like-minded, that understood that the problem. We're able to admit the problem. We're able to offer suggestions and solutions, and we came together and we built Ruka. I will tell you, if you describe me in a nutshell, so I'm scientific, it's the way I see the world, but I have a very empathetic heart. So I'm always thinking about the patient. I'm always thinking about the person and sort of marrying those two, science and empathy. That's me in a nutshell.
So it sounds like you moved to Illinois to help take care of a loved one, and uh, essentially kind of leaving behind, or kind of perhaps continuing on the side, your life as a scientist back in California, which I mean sounds like really you had it all. Being a scientist in a big university in California, in Los Angeles, like, what's there not to love about that, right? And then you took that and you moved uh, to Illinois, and then you came face to face with just kind of like, even with commercial insurance, what people face, the barriers they face to care, and the stigma they face to care for, especially for like mental or behavioral health. Um, so how did you go? How did you overcome those barriers? I know that um, you're passionate about like uh, community-based care, mobile care, um, and overcoming geographic and systemic barriers. Um, can you tell me more about that? Like, so we know you faced a lot of barriers. Like, um, how did you even come up with the idea to, I'm going to do this myself?
To launch an institute.
Yeah.
Okay. Well, that's a very, very long answer. I'm going to try to just hit key points. Number one, connecting with the community was key. I think when you and I talked previously, Sam, I talked about in launching the institute, we didn't launch treatment services right away. We launched wellness. We launched group wellness services, and that was intentional for two reasons. One, people were isolated, and we needed an activity that could bring them together, both bring them to us so we could connect with our patients, our people in our community, but also bring them in connection with one another. And the second reason for that was we knew that one of the issues, or one of the services, if you will, lacking was really wellness. People, kind of saw health as, well, you're treated, then you're good, right? And it's like, no, 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 no. There's this continuum, right, of wellness, and we should all be continuing to seek wellness in our lives. And, until the day we leave this earth, you can continue on that wellness journey. So we wanted to create a continuum of care for our people where at any point in their life, maybe they're really, just barely making it and treatment is more appropriate. So we have something for them, but maybe they're in recovery, or they're, managing well, whatever, the ailment is, or maybe, they've been treated and cured, so to speak, right? But they're maintaining their wellness. We wanted to have options for um, all variations of humanity in that community. So we started with wellness. How did we measure those barriers was your question, or how did we approach those barriers? We measured them, and that took a while. We needed to understand and use quantitative data, qualitative data. Um, we needed to understand them. I could I knew the suicide rates were high. I knew overdose rates were high. I knew people were isolated, although there wasn't really good metrics around that. But just driving around the community, I mean, the counties that we were looking at that time, there were, it was over 2,000 square miles and there were 100,000 people. So you can think about just the vastness and how people exist in sometimes there's the most populous are these county seats, which usually have between 5 and 15,000 people. And then you have all these little punctate towns around the county that could have 50 people, they could have 200, they're just these small little communities, wonderful communities that each have their own character. But you can't assume that because you're in the county seat offering a service that everybody in these small towns knows of the service, buys into the service, trusts the people that are offering the service. You really have to approach the rural landscape by connecting with people in every little community. So we measured those barriers and then we strategized on how we were going to add those treatment services. And the wellness services took off. They were very well attended. It was really interesting. A local church, before we ever had a building, said, our sanctuary is empty 6 days a week. Use the church sanctuary and offer yoga. So we had our first yoga classes in a church sanctuary. It was so cool. Our workers would come in, we'd move all the seats to the side, we'd lay out the mats, we'd get the eucalyptus and the lemongrass going, and we would, in the meditative music, and we would provide services. It was the sweetest thing. It was wonderful. And we really, a lot of people came and that's how they encountered us and met us. We also had a couple of Hope conferences initially just to bring people together. We had hundreds of people attend those, had breakout sessions on various topics. We brought in experts from other areas just to connect and just to say, hey, we're here. We don't know what this is going to look like yet, but we want you to know that we're here for you and we're working on it. Like we see these long-standing barriers. We see these inequities that you've been fighting an uphill battle for years and years and years, your entire families, generationally a lot of times, and we're here for you. So that's how we started, was connecting and measuring.
Wow. Um, so you knew what to measure from your experience with your loved one and just your science background. Because I mean, how do you choose which KPIs or which things to measure, what things not to measure, and because in the rural setting, a lot of times the data is not necessarily there.
It's not correct. One of the approaches we used was to develop relationships with stakeholders that we knew had entry into the lives of people that were suffering. One of our earliest partners was law enforcement. So we had a local police chief that is a dear friend of mine now. We've built wonderful programs together in the last 8 to 10 years. And he had just moved from a more urban area, but he had grown up in a rural area in Illinois. He understood the challenges, but he had also worked in a department that had resources, that had a really wonderful vision and outlook on mental health and using non-enforcement contacts to help people. So they weren't just about arresting, and laying down the law. It was, hey, we're here as as your partner in this community to help get you to where you need to be. So the law enforcement in our community were a huge help, and partnering with them, we were able to talk specifically about the barriers. What did they look like when you encountered folks in the community and you knew they had untreated mental illness? And that was the whole reason you were encountering them as police officers in the first place, again and again and again, was their untreated illness. Where were they? How did they present, right? And we were able to get to go actually co-respond with them. And that's how we built our mobile crisis service, is we started our therapists started writing in cop cars and going to these persons that were suffering and building rapport with them and finding ways to link them to the services that they needed. We operated that under a criminal justice grant to our county, and we were able to build that service with our county, our law enforcement. And it was a wonderful way to start. And then 988 and the state of Illinois, and CESA and all of the wonderful changes that occurred in the state of Illinois regarding mobile mental health and substance use crisis response came the year following. And so we were able to use what we had built and continue to expand it and really build that mobile model of care, which is what people need. I'm all for telehealth. It's a wonderful tool. It is not the answer for rural, though, because people that are severely decompensated and chronically ill, they need a live person in front of them, oftentimes to come into their home or to meet them in a park or to meet them, wherever they present, and to be able to sit with them and build trust and build rapport and let them know, hey, we're not here to do anything to you. We're here to do something with you. If you consent, if you're open to that. Sometimes we meet with them 10, 20, 50 times before they consent to wanting help and assistance, but we continue to just invest in their life, let them know we're there for them. So this is a very empathetic approach to, how to build trust with persons that are really struggling, and it works. So that's one of the kind of pillars of our success and how we were able to do what we did is it's a very empathetic approach to persons that are struggling.
So I know in science, scientists aren't always the most collaborative people.
What are you
If
talking about?
um, so it's a lot of times there's kind of what's the word, like they don't, they're weary of other people maybe stealing their work or kind of
Mhm.
or profiting from their work, etc. And correct me if I'm wrong. That's my impression as an outsider. Um, but and overall, honestly, people are, we're not like in school. We're trained to be, um, individualistic and you know like teamwork is discouraged typically because that's called cheating, and right. So
It's funny.
how did you how did you learn to be collaborative versus like you know just going at it alone and just plowing whatever's plowing over whatever's in your way?
I credit my mentors. I had phenomenal mentors in my PhD, Dr. John Solero, who's still at University of Illinois, Chicago, Dr. Peter Buttrick, who most recently was the chief of cardiology at UC Denver, um, and my postdoc mentor, Pei Ping at UCLA. Every single one of them, my entire training participated in multi-institutional collaborative efforts. It was incredibly exciting and thrilling work because of that, because we understood that we played a very specific role, but it wasn't the role, right? It was a role in this collaborative network of investigators. And I'm hardwired that way because of it. I also believe that as an individual, I'm also very much a connector, a galvanizer, someone that brings people together. I very much philosophically see life as, you can create something that's greater than the sum of its parts. I mean, that synergism is something that it will always be a part of my work, bringing people together, because when you operate in silos, everyone loses. Your work doesn't have relevance. Your work doesn't have applicability or generalizability. You learn. I'm a lifelong learner. I study my colleagues. They, I think, study me. We learn together. we have healthy debate, we sharpen one another, we are, constantly iterating, trying to find the best solution. And a big part of that is getting people in the room that don't agree with you. That's one of the most effective ways to come up with the right plan. It's to get people in the room that are going to have very strong opinions that don't align with yours. And then you can have healthy debate and iterate and use, data and logic and reason to find the best solution. And so I credit my mentors. They were phenomenal. I had an extraordinary career in academia, and I still am very close to all of my mentors and use them as, they're my friends, but also just, every once in a while we'll get together and just kind of talk about life, and they're incredibly insightful still to this day in my life.
So what you're saying is my experience with scientists in terms of them being kind of isolationist and that kind of thing is
You've
completely
met the
wrong.
wrong ones. Yeah, no, I understand that too, being protective of your work. We have to think about intellectual property. I do that in my own work, but I have wonderful attorneys for that. But you have to be able to, share. And I will say this, if, I believe, when you're funded by public dollars, especially state, federal funding, like your responsibility is to build something that you can share with the world. If we're using public dollars to do it, that's your responsibility. And not everybody agrees with that, but that is also the way I operate. And anytime I'm building, strategizing, innovating, developing, I'm thinking of the greater population in mind, because it's just the best way to use, it's the most efficient use of resources. Why do we need to reinvent the wheel? Get people at the table that have done what you want to do and then innovate it and make it better.
So in essence, by collaborating or having a collaborative mindset, uh, you take potential competitors and turn them into collaborators.
That yes, I mean that I not that doesn't always work. But absolutely. I mean, I can't think of a reason that I wouldn't work with someone unless there was, some sort of malicious intent, which 99 times out of 100, that's not the case. So, yeah, I think yes, that's exactly right.
Is that kind of your secret to creating a scalable solution in terms of like if you were to name one or two things that really are key to creating something that's scalable, or in your experience, what would those things be?
That connectivity, like you said, connecting with the population you're serving, connecting with local stakeholders doing similar work or that are key entry points to your patient population. Understanding solutions are, collaborative, and you need to utilize, especially in rural areas, utilizing resource utilization is critical because resources are always limited in rural areas. I think I can use the word always.
Hmm.
um, so instead of looking at it as we need to build this and be all things to all people, we say we can do this part, but then there's 37 agencies that can all do 37 parts. And the hard part isn't it is connecting that in an efficient and streamlined way. So building collaborative networks is how you scale. It's how you build something meaningful for a community, and it's how you scale.
So now that you have all this experience with knowing how to connect people, knowing how to connect organizations, seeing really accomplishing something pretty rare in terms of having a successful story on your first try. Usually, like for your first try, is like investors won't, like are not happy about investing necessarily in first-time entrepreneurs and so on because like they know that 9 out of 10 will fail. Um, and by the time there's someone's like a second or especially third-time entrepreneur, then they're kind of more keen on investing or talking with them because they've been through the grind, right? So
Mhm.
um, so with all the knowledge you've gained and so on, what do you think is next for you?
I can give you a theme. Health equity is always my next. I will continue in this fight until I'll continue fighting this fight until every person that is underserved has equitable access and to care and quality of care. I launched a consulting company recently, and I am thrilled to be able to take these lessons learned from the field. And I still feel like I'm in the field. I, I just have such a strong connection to the patients, but I using that the last 10 years and being able to just help providers in this work that don't have the time to innovate, iterate, improve, think outside the box. They're just trying to keep their agencies open. And I know that exhaustion, I know what that's like. It is incredibly difficult to run an agency in a rural area. And there's always, you always feel a little bit behind and like you're just trying to catch up and cover the bases. So being able to come and partner with agencies and help them make some easy, simple fixes that can have big impact is one of the things I do really well. So, strategy, innovation, community action are really my three strongest. I also write grants. We had 12 revenue streams that we had layered, and we were able to provide the type of care that people deserved because we had such a diverse portfolio of revenue. I can also help agencies think in those terms as well. Billables very often don't cut it in being able to sustain your agency, but also there's ways to increase your patient volume, which is a chronic issue in rural providers. Is low patient volumes make it really, really hard. Same fixed costs, low patient volumes make it really, really hard sometimes to keep your doors open. So there's a lot of strategic fixes and changes that aren't that uh, challenging to implement. It's just our leaders are so taxed just keeping their doors open that they need someone to come in and work alongside them and help them do those things. So that is right now one of my best gifts to this. I would say that's my best yes at this point. And there's a lot happening in rural with respect to like rural health transformation coming out of Washington. I'm so excited about the investment in our rural areas in all 50 states that is on the horizon. I am extremely motivated to help to make this work, to make to see measurable, sustainable change in our rural areas. I have a healthy caution, I would say, in how we approach this to make sure that we are working well with rural soil, that we are not doing things to them, but doing things with them, and using rural champions to come into those rural communities and help establish trust and buy-in and help our rural communities see that not, hey, you're running a marathon and now we're just going to put this 1,000-pound load on your back and I just need you to carry this for a while. Like that's oftentimes what these initiatives feel like. It's like, I'm just trying to sustain my agency and now I got to do all this other, right? it's so trying to keep that load light on rural communities while we build these elements of transformation into the care, and everybody wins that way. But this isn't a bailout. This is a transformation. So that's very, very different. We need to have sustainable change that helps our communities for years to come.
You mentioned trust, and I know at least one of my earlier guests has made a point of that as well, in terms of really to have an impact on the community, you have to establish trust with them. Um, Otherwise, it's much less likely to succeed. What does that like? What does that mean to you?
Yeah, that with respect to rural, that's challenging. This is this is not in any way, blaming any component of this, but there is a general skepticism in rural that um, a lot of the models that are funded at the state level are built using urban data. They're built and they work very, very well in geographic areas of our state where there's dense population. And then rural areas are expected to operate these models and they don't work. And it's really, really hard to make them work. And then we don't get the funding for those programs because they don't work. So that's a very real problem. And that's something at Aruka that I encountered often. And that is something that our state was very open to hearing about and, working with us in whatever ways they were able. But that's a waste of resources. Oftentimes we don't need as much as with respect to dollars. We just need to be able to have the flexibility to provide the care and to implement the service delivery in the way that works for a rural landscape. So that is kind of a very concise example of why there isn't trust in rural areas. There's a whole myriad of other things as well. Environmental differences, life differences, political differences. I mean, there's a whole slew of other reasons why there's kind of this divide oftentimes. But I think me, others that are doing similar work, we can be that effective liaison in finding a common denominator between, our state and the rural areas by being the translator of the hope and the promise both ways, right? This is how we're all seeing it, right? Our state, our leaders need to hear that. This is how the state's seeing it. We're only, being that effective communicator, interpreter, and finding common solutions, finding and developing a shared understanding and getting everyone on the same page so we can effectively develop, build, implement, and sustain these changes.
So it sounds like it's multifactorial, and as in one of our previous conversations, you mentioned the word heterogeneous, um, in terms of like not every rural community is the same. They're all, they have their differences, and it's not, and so you have to account for that as well. And as and then you also have to account for the differences between rural and urban communities, and that's not often looked on, or kind of uh, it seems like there's a lot of complexity to that, and uh, essentially that kind of the differences kind of get ignored, and then whatever the plan is doesn't end up working out for the rural community because it wasn't planned in a way that would would guarantee its success or make it more likely to succeed.
Or not championed. Oftentimes it's just a lack of understanding of kind of what the intent is. And I think that, you have to have champions on rural soil that understand the intent of what our, state, regional, whatever governmental entity, in this case, we're talking about, where however the funding is coming through, right? We have to have that shared understanding and build that trust that, hey, we're all on the same team here. Like if we all work together on this and we, keep our skepticism at bay and we lean into this and we trust that, what we're trying to do, everyone has, good intentions here. And we're not just an afterthought, or we're not just, it's not just obligatory. Like there's good intentions here. I think it's, that just takes a lot of work to do that. It doesn't happen organically. You need champions on rural soil. And this goes for all 50 states. This isn't something unique, to one state, but having that shared understanding throughout the state, to all of its different geographies, to all of its different populations. And going back to the heterogeneity of a rural county, you can't just operate in the county seat where it's the most populous. You have to have that buy-in and that understanding in all those little towns. And that takes time. I mean, it's engaging mayors, it's engaging community leaders, it's, talking to them about the why, um, and helping them see the vision here, and addressing those points of skepticism, addressing historically some of the ways they feel they haven't been supported, right? And then helping everybody just, get on a positive trajectory together, and to lean into the change. That's how you adopt these things. That's how you can adopt these things at the level of the community.
It seems like you have you've seen a lot of stories in the rural space in your experience, and do you have kind of like an anecdote or a particular story that kind of sticks out in your memory about kind of like where someone was uh, where someone's future changed because of the services or the help that you were able to provide them with?
So many, so many stories. Um, I'll use one of a very, a very chronically ill individual that had a lot of cards stacked against her. She grew up in a very um, abusive, neglectful environment, and she was doing the best that she could. Had um, she'd been homeless for most of her life. She became pregnant, and at that time was using she was in active heroin use. And we met her through our law enforcement partners. And I say we, I'm speaking about the agency that I used to work for. And because we were so outside of our walls and out in the community in vehicles, meeting people where they were at in their homes, places of work. In this case, I believe one of our first meetings was in a community park. And we were able to build trust. We were able to build rapport. This person, because of the OB desert that plagues most rural areas, and because of the provider stigma that is very real. So if a person goes into their OB appointment, I'm not saying every OB, I'm not saying every provider, I have to be careful. But in many areas, if a person in active heroin use who's pregnant walks in for an OB appointment, she will be called many names. She will be highly stigmatized. She will be discriminated against. She will be made to feel very, very small and very unwelcome. and sometimes won't be accepted as a patient, which technically is illegal, but that's the reality. So she didn't have any interest for those reasons in trying to get prenatal care. So what we were able to do is we had a federally funded program at that time from HRSA that funded care, this sort of outside of your walls care for women in active substance use disorder that were childbearing age. So we were able to surround her with midwives and doulas and recovery support specialists to provide proper care, literally transport her, go with her, advocate for her, not let anybody say anything negative to her, right? We're there with her in those appointments, get her the proper care. And she was able to have that baby enter recovery while she was pregnant. And that baby was born not addicted to opioids. So, and she's now doing very, very well. Mom and baby are doing very, very well. And that's just one of the many stories where this sort of outside your walls, anyone, anywhere, anytime care, it can change. It changes generations. I mean, that was a point in that lovely, lovely person's life where because we were able to provide care in the way we should outside of our walls, meeting her where she was at, that changed the trajectory of her life and her babies.
Wow.
So that's a very common example of what we can do when we are able to innovate and build these service delivery models that keep the patient, the rural patient at the center.
Yeah, that sounds like a huge impact. Um, I think one of the questions that people usually have about not just rural health, but just staffing in healthcare in general is, um, I mean, you have to have people to actually go and do this outreach and meet people where they are. In this economy, as they say, how are you able to do that? How are you able to find the people to actually staff everything?
You just identified every CEO's, challenge right now. It is the talent in rural areas is incredibly hard to find. The talent you just described for the mobile outside your walls care, even harder. I mean, extraordinarily, like much more difficult than just finding kind of your normal healthcare talent. It's a wiring. They're wired like first responders, mobile crisis responders that do very, very well with that work in that can work outside the box. They don't need to have people come to them in their kind of safe, secure office that they can go out. It's like law enforcement, they're wired like first responders. It's like EMS. Um, so it's really challenging to identify those individuals. And I feel so fortunate that we had, I believe, some of the best in the business at the agency I worked at. And when um, I I will tell you one thing I did that was wise is I pulled in that chief of police to interview with me, and he could help ascertain those skills that were really, really critical for that that mobile responder profile. So once again, use your partners. Don't think you have it all figured out. Use the collective knowledge of who you work with. We had extraordinary mobile crisis providers, and they're still doing the work today. And I can't say enough about just the quality of the talent, but the rarity of the talent. And that's a much bigger issue, I believe. That's a training issue. We need to take a long, hard look at how we're training our mobile responders for crisis, for behavioral health crisis, because emergency responders for health, right, is our wonderful paramedics, right, our EMTs. And Um, if I were seeing the future, I'm thinking there's a way that we will start to see our paramedics as doing more emergency response that goes beyond emergency transport, but doing more of that mobile response in our rural areas because it just makes sense. That's the way they're trained. That's the way they're wired. And then you don't have to try and take, a therapeutic workforce that isn't trained that way and try to make them a first responder, right? It's a training just inconsistency. So anyway, there's going to be a lot of changes in how we train our professionals, particularly for rural areas where you have to have that mobile response to be effective.
So it sounds like a lot of it depends on training and the resources available for it to really align the people with a kind of first response mentality with what you're doing and kind of let them know that you're there um, and are essentially looking for them to follow their passion and help them treat patients.
Mhm.
What kind of so going forward, like you mentioned, you have your consulting company. You're looking to help others scale. And what would be the ideal type of connection uh, that you're looking for, whether it's on LinkedIn or outside of LinkedIn?
Can you repeat that? What's the connect?
Yeah. What kind of so what would be the ideal kind of person that you're looking to connect with?
I mean, inherently, they need to believe that we can really make change. And I don't, if you're a policy person, if you're a person in the field, or somewhere in between, if you believe wholeheartedly that we can make sustainable change in a rural area, I'm your person. Because that belief and that passion is what's going to drive you because you will encounter many more closed doors than you will open ones. And you have to have that grit and tenacity to fight through and continue to believe until you achieve it. And I don't, I work with so many different types of people and we haven't even talked policy, but I've never considered myself a policy person, but I probably do more policy work than anything at this point because, if you have to change policy to make sustainable change. So I love that work. I really do. Um, there's so much efficiency in policy that is untapped. You don't need to you don't need to, ask for additional dollars. You just need to make often cost neutral changes just to make field workers' lives easier, removing the administrative burden, just simple solutions that just increase efficiencies. And they don't have a high cost to them. And I think those are the things I get excited about because it's like, why are we making this harder than it needs to be? Let's just focus on cost neutral wins right now. And let's just open up some of these bottlenecks for our rural providers. Um, and I mean, there's a lot we can do in just that space right now, especially with the impending, Medicaid cuts and all the challenges we're going to see as a community. But let's focus on what we can do. And there's a lot. There's a lot we can in policy alone. So I get excited about those things because those are untapped, opportunities.
Seems like the ability to find people who know they can or know they can change things or really or just are want to at least try to change things and have a goal of really making an impact in people's lives. Um, that's your ideal connection because you can help them essentially change the world and especially when it comes to oral health.
Yeah. It's a lining of purpose and passion for me, and intention. What are you here for? Are you here for selfish interest, or are you here because you truly are about the fight for rural people and making their lives better? So that's the most important alignment for, the work that I do. Um, and I've turned down working with, various entities or people because of that, because I'm like, it's not aligned, and you don't want you don't want the work out of me, or you don't want my work if we're not aligned in that way. Trust me, it's not worth your time or money. Like, I will do my very best work when we're aligned in that way. So I it's a really good way to vet. Make sure
Absolutely.
it's make sure it's always your best yes.
I love that.
It could be a
Well,
little off-putting when I'm first meeting. I'm like, what's your passion and purpose in this world? People are like, whoa. I'm intense. I will not sugarcoat that. Like, I get down to it. It's like there's no time. Let's just get right into it.
um, yeah, better to ask at first than have to wait 6 months and then ask later, and then by that time you've already kind of put a lot of energy into something that's not aligned.
That's right. That's right. Alignment is 90% of it for me. We'll do great work if we're aligned.
Well, Dr. Skirks, thank you so much for joining me. This has been amazing. I love learning from your experience and from your passion. Um, and
Likewise, Sam.
yeah, thank you for taking the time. Thank you all for joining us on We're All Patients podcast. Hope you enjoyed the show, and we'll see you on the next episode.
Take care.